collaboration between McMaster University's Global Health Office and the Departments of Anesthesia, Surgery, and Obstetrics and Gynecology. And the purpose is to bring together faculty and residents to promote our activities and partnerships and recognize and inspire volunteer services by the faculty and trainees, as well as to develop some educational resources for those interested in global surgical care, as well as to generate and support interdisciplinary research. Typically, our seminars and rounds feature the work of faculty and physicians that are in a more advanced stage of practice. But this evening and this past spring, we are highlighting some recent and current trainees who are also part of this global health community at McMaster, Doctors Higgins and Dr. McDonald. They'll be introduced prior to each of their presentations. So thank you to everybody for joining. Thank you to Doctors Higgins and McDonald for agreeing to present tonight on some very interesting topics.
I'm Joel Hamster. I'm an anesthesiologist at St. Joe's, and it gives me great pleasure to introduce a friend and colleague, Dr. Onica Higgins. I've had a chance I've had the opportunity to know Onica for, I think, eight or 9 years now, and it's just wonderful to see how her career has developed, and I'm so glad that she's able to chat with us tonight. So Dr. Higgins is a recent graduate of the McMaster Chronic Pain Management Fellowship. She recently completed that this past spring. And she is an anesthesiologist intensivist with the Department of Anesthesia and Intensive Care at the Georgetown Public Hospital Corporation in Georgetown, Guyana. She has served as an anesthesiologist intensivist there for the past 5 years and is also an adjunct associate lecturer at the University of Guyana. And she now, upon returning to Guyana, has the Herculean task of setting up an efficient chronic pain service at GPHC. She's passionate about a lot of things. One of them, probably very near the top, is relieving the suffering caused by chronic pain, but she's also passionate about research, patient safety, resident and learner well-being, and she continues to advocate strongly among the faculty and the administration for these issues. Dr. Higgins is thrilled to have taken her passion and enthusiasm back to Guyana to serve the Guyanese population, and I really look forward to hearing what she has to present to us about her topic, chronic pain management in Guyana, then and now. So please, Dr. Higgins, take it away.
Thank you. Good evening. As Dr. Hamster has mentioned, my topic is chronic pain management in Guyana, then, now, and beyond. Next slide. So first, I just want to give you a little insight of where Guyana is. So Guyana is in South America. It's the only English-speaking country on South America, and we embrace a Caribbean culture. This country is also known as one of the countries wherein lies the Amazon rainforest, also known as the lungs of the earth, and it is known for the Kaito Falls, the highest one-drop fall in the world. So I'm just mentioning this because I know most of you will know where Guyana is, but it's something that was always asked when I was over in Canada. So I'm just bringing this into perspective. Next. So my objectives today are to discuss the scope of chronic pain management prior to my training in Canada, and to give an update of the current practices and some of the plans for the future in the chronic pain management service at GPHC. Next. So the Georgetown Public Hospital Corporation is the only government-owned tertiary institution in Guyana. This is the hospital where all of our residents and fellows are being trained. In 2018, the head of medical services basically mandated that the anesthesia department commence a chronic pain management service. It was basically non-existent in Guyana before, and there was a need because of a lot of patients, especially orthopedic patients that had refractory chronic pain. Unfortunately, there was no staff trained in this specialty. However, myself, along with a few other anesthesia providers, we opted to jump on board and work in this area. So it was a referral-only service. The options or the management options offered were pharmacological management, physiotherapy, and acupuncture. At that time, regional anesthesia was not, its practice was very limited within our institution. And of course, we had very limited resources, such as epidural kits. They were really limited. So this was not offered on a regular basis. Next. So one of the patients in my very early years at the clinic was EA, a 62-year-old male with severe right hip pain secondary to osteoarthritis. He was awaiting hip replacement surgery and was receiving pharmacological management, physiotherapy, and acupuncture weekly. This patient initially came to our clinic ambulating with a stick, a single prong walking stick. He eventually came with a rollator and then a wheelchair. Then he was deemed an unfit candidate for his hip replacement because of significant disuse atrophy in the lower limb, etc. Now, this is one of the many patients that I remember from my early days, my earlier days working in the clinic, because I always thought that if we were able to do more for him to help with his pain relief, he would have remained ambulant, would have been able to continue physiotherapy, and by remaining ambulant, he would not have had the significant decline in his physical status to reach to disuse atrophy and being unable to have his procedure done. So many of these patients made us realize the need of having someone trained in this area and for us to really try to optimize what we can do for our patients. Next slide. And so I embarked on my training in Canada in June of 2023. Initially, this was really overwhelming because it was a lot to grasp. It was to familiarize myself with the use of electronic medical records. It was getting hands-on in using the ultrasound machine again, and with absolutely no exposure in fluoro-guided procedures. However, I was able to grasp a significant amount of skills. And so by the end of that stint, I was able to efficiently perform the ultrasound and fluoroscopy guided injections and radiofrequency procedures. I was able to administer chronic pain infusions to patients and just to be able to go through the diagnostic aspect to determine what pain generators should be targeted. Next. Other aspects learned was I had a better appreciation for the role of the other allied services in pain management, especially the psychologists and the physiotherapists, and even the role of the dietitian and social worker, because we're all familiar with chronic pain. It needs to be treated holistically. And as such, we need to always try to have an interdisciplinary approach, or at least a multidisciplinary approach. So being at McMaster and seeing how these different specialties interfaced to manage their patients, it was awesome, and I appreciated that. And I'm now able to come and try to mirror this as close as possible. I was also able to see how we can use our time and resources more efficiently, and was exposed to the simulation for learners of McMaster, and it's something we're working on to implement at GPHC also. Next slide. So at the end of my fellowship, leaving Canada, it was definitely a bittersweet moment for me. I know I would have missed many of the modern conveniences offered in the first world, but I needed to return to my loved ones, and I was really enthusiastic to come and serve the chronic pain patients here in Guyana. Next. So upon my return to Guyana, I came and submitted a proposal to the administration for a daily chronic pain management service. This will include consult days, fluoroscopy days, ultrasound guided procedure days, and even to have an infusion suite eventually. This procedure has been submitted. I was able to also submit a proposal for an audit of the current service that we have in an effort to assess the needs. And this research proposal has also been submitted and accepted, and it received approval from the research committee at GPHC. What was a bit more tricky to deal with was protocols or guidelines for referral, admission, and discharge of patients from the chronic pain service. This, although I came with a proposal for that, we had to do some amount of adjusting and tweaking, and this proposal should be presented at a medical advisory committee in December 2024. It is only until after the protocol proposal is submitted, then the hospital will actually decide to further invest in resources for the pain management clinic. But continuing medical education sessions were held, and so that was in an effort to raise awareness to chronic pain and what can be offered. And this was well received by the medical fraternity in Guyana. Next slide. So the challenges at the moment include an office space, or just to have space for consults and operating room time for fluoro-guided procedures, some equipment, staff, and of course, adding new drugs to our formulary. But this is basically a work in progress, and it has already commenced, and we're gaining great headway. Next. So what does our service look like at the moment? There are 2 consult days where 8 patients are booked every Tuesday for the new consults, and these patients are seen by the interdisciplinary team, which consists of myself, a physiotherapist, psychologist, and our acupuncturist. The second day, we basically do follow-up on patients that would have had a procedure done or just following up on medications. Both days are used to do ultrasound-guided procedures if indicated. And if there are additional patients that require procedures done, I bring them into the operating room when I'm actually there to do these procedures in the block room. And there we do ultrasound-guided injections and epidurals. Next. So the scope of the current practice is or are the interdisciplinary pain team assessment, medical management, ultrasound-guided pain procedures, and acupuncture. We are yet to commence the fluoro or the fluoroscopy-guided procedures and radiofrequency procedures. Next. So I'm at my second case. The second patient I will highlight is a 63-year-old female with severe bilateral osteoarthritis of the knee. This patient again was awaiting knee replacement surgery, managed with medical management and acupuncture. Our average pain score was 8 out of 10, and she spent a significant portion of our day relaxing in a recliner because of her knee pain. This pain had ultrasound-guided genicular nerve, phenol neurolysis done, and she now reports a pain score between 2 and 1, 1 and 2. She is able to do our morning walks. She has returned to her family business to basically assist working on a daily basis and is now able to do gardening, which she so wanted to do. Now, the difference between this patient and the first patient is that now we're able to offer a bit more. Patient number 2 can remain ambulant, can actually remain productive, and she has a better chance after our knee replacement surgery. Next. Case number 3 is of a 37-year-old male, computer technician, quite a lot of typing, diagnosed with classic carpal tunnel syndrome, on no medications. In Guyana, men are they just don't like having meds. It's just something that we have to deal with. A female patient is more likely to comply. Anyway, this patient had a ultrasound-guided median nerve hydrodissection done. And at his follow-up in 2 weeks, he reported an 80% relief in the numbness, the tingling sensations, and a decrease. So he had an 8% decrease in the intensity of his symptoms, and there was a significant decrease in the frequency also. I am highlighting these 2 cases to say that we're only offering ultrasound-guided procedures right now, but it is still impacting significantly on the patient's lives. Next. So in the end, the plan is to have a comprehensive and a complete pain management service. I have colleagues that are focused on regional anesthesia and acute pain. I will be focused on chronic pain and transitional pain. And then we have another anesthesia provider that is very focused on implementing an epidural service in the obstetric theater. So within our department, we will have a comprehensive and complete pain management service, and I will be focused on the chronic pain aspect. Within within the pain management clinic, we now offer management to patients with persistent post-op pain, and this is not a service that was previously offered, and we're seeing excellent results. So the plan is to continue with our interdisciplinary pain management service, work on optimizing the medications that we have available, commence radio frequency ablations and pulsed radiofrequency, and have pain management infusions on board. Next. This slide I placed here because I remember that there was a call. There's a call in 2004 at the Geneva Convention, and that call is for global access to every patient. Every patient should have access to pain management, and it is considered a basic human right. Now, we will not all start on the same playing field. I consider Guyana to be over here, this little guy. And because of our position or the position that we're in, it may take some more time. It may take some more resources. I know definitely we need additional pain management specialists to be trained, but eventually we hope to be able to offer a service that is basically equal to what is being offered in any first world nation to all of Guyana. Next. In closing, I want to say thank you to Dr. Hamstra. I want to extend a thank you also to Heather, Mike, and all the folks at IOP, the McMaster administration and staff that have worked behind the scenes, and those that I've worked with in the clinics also. Thank you so much. And the staff and administration of GPHC. This brings me to the end of my presentation. Thank you.
So our next speaker is Dr. Madeline McDonald. I met Madeline when she was in her first year of training, and she expressed very early on an interest in getting involved in some global surgery and social medicine research. And she came up with a really interesting project, which we're going to hear about this evening, that sort of is it reaches the underserviced within our own country, which of course is something that we don't typically think about in a country like Canada. So, but she's going to talk about that. Dr. McDonald is in her third year of general surgery at Mac, and she's just recently completed a very interesting master's, which I hope I'm going to hear about at some point, in evidence-based social intervention and policy evaluation at Oxford in the UK. Her interests include global surgery, health policy, and as mentioned, improving access to surgical care for underserviced groups. And her recent research focus is on surgical care and outcomes for people who are experiencing homelessness. So, Madeline, if you want to just introduce your talk, and then I think we're going to play the recording. Welcome and thank you.
Hi, everyone. Thanks, Dr. Levis. And thanks, David. Let me record my presentation in advance. I'm just still at the hospital, but I'll be around for questions if anyone has questions at the end. My name is Madeline. I'm a PGY3 in general surgery here at Mac. And thank you to David and the MacGlObAS team for the opportunity to present some of our research on surgical care for people experiencing homelessness. We're going to touch on some local Hamilton data and then some evidence from abroad. I just want to thank everyone who's been part of the team, including a number of students, other residents, and staff who've contributed to this work. And maybe most importantly, Marcy, who's been our lived experience consultant. So Marcy has lived experience with homelessness and has been critical in helping us understand and contextualize our findings and ensure that we're responsible to the folks that we're studying. MacGlObAS has supported some of this research through the Surgical Scholar Bursary, as well as some presentations at Bethune Roundtable through a bursary as well. I want to preface the talk by saying that I'm not an expert in this content. I don't have lived experience in homelessness. Anything shared here comes from academic or clinical interest. And on behalf of the group, the motivation for these projects come from observing barriers that people experiencing homelessness face in clinical settings and questions about kind of unmet need of care. And our collective viewpoint is that structural and social determinants play a larger role in health than individual determinants. And this kind of anchors and informs our approach to this topic. So we'll talk a little bit about kind of background information and then our local Hamilton context, and then some evidence more broadly. Homelessness itself includes a wide variety of situations that look unique to each individual and can also be fluid over time. So we like the wide definition by the Canadian Observatory on Homelessness, which includes folks who are unsheltered, emergency sheltered, provisionally accommodated, and at risk of homelessness. This research is situated in urban populations in the global north because this is the context we see in Hamilton. And other contexts throughout the world are important and deserve research, but don't translate well to our current context. And throughout the talk, I'll use the terms people experiencing homelessness and unhoused populations interchangeably. Different groups prefer different terms, but essentially the commonality is that homelessness is a situation that people find themselves in and not a defining factor. We started to learn more about this topic through a scope review to see what evidence exists for surgical care for people experiencing homelessness. Similar to bodies of evidence showing higher burden of medical and psychiatric disease, we found that people experiencing homelessness also have high burden of surgical disease. This included more traumatic injuries, less disease screening, and often presenting with more advanced disease with malignancies, for example. They experienced significant barriers to accessing and continuing with follow-up care throughout the surgical spectrum of care, and often presented with more acute problems in emergent settings, for example, in the emergency department. Most of the studies that we found were retrospective and descriptive in nature. So, for example, experience of one site with this population, and the majority came from the States. As we know, the States does not have universal healthcare coverage, so the applicability to our setting may be limited. And so next we set out to explore surgical care here in Hamilton more specifically for this population. We don't have an accurate estimate of the number of people experiencing homelessness in Hamilton at any one time, but approximately 3,000 individuals are using shelters annually. And other studies have said you can probably triple that number to account for folks who are living rough and provisionally accommodated. We have the Shelter Health Network, which is run by family physicians, nurses, internists, and psychiatrists, and provide primary care within shelters and transitional housing units across the city and are the mainstay of primary care here in Hamilton. So we did a chart review of Hamilton Health Sciences with the goal of describing patterns of surgical care, including surgical consults for patients both in the emergency department and admitted, any patients admitted under surgical service or had procedures done by surgical service. This was a retrospective review over 1 year across Juravinski and Hamilton General. Patients were identified by a postal code that aligned with one of 30 shelters or transitional housing units across the city, or their postal code was listed as NFA, which is no fixed address. There's one similar review was done in Ottawa, and so we wanted to make it comparable across the two cities. Over 1 year, there were 90 unhoused patients who had 129 encounters with surgical services. Overall, there were 41 emergency department visits and 88 admissions. 18 were trauma activations, and the most consulted services were orthopedics, general surgery, and plastic surgery. The average age of patients was 45, or 20% of patients were female, and the most common comorbidities were substance use, smoking, and other psychiatric disorders. There were 85 procedures completed for 58 patients. The most common was surgical fixation of a fracture by orthopedic surgery, or incision and drainage of infection by plastic surgery or general surgery. The average length of stay was 16 days. 24% of patients left via self-discharge or against medical advice. This was significantly higher than ranges of similar populations in other contexts, but interestingly was more in line with populations of people who use drugs and self-discharge rates in that population. And so we think the high rates of substance use within our population here in Hamilton explain the high rate. 22% of patients had a complication either in hospital or at their next presentation, and 17% were readmitted within 30 days. These two were in line with ranges described in other studies. While it wasn't a goal of this study to examine factors that led to self-discharge, we noted from literature, both in unhoused groups as well as in people who use drugs, that stigma, discrimination, undertreatment of symptoms such as pain and withdrawal, and rigid policies in the hospital setting have been described both in unhoused populations and in populations of people who use drugs. And so likely either the combination of these and the overlap is what explained high rates of self-directed discharge in this population. This also points to kind of lessons learned and potential areas for growth within our own institutions. Next, we wanted to capture surgical patterns within outpatient surgical care, and so we did a review of the Shelter Health Network, which again is a network providing primary care to these folks in Hamilton. So we wanted to include all referrals for surgical consultation as well as procedures done in an outpatient setting. So this was a retrospective review over 2 years, pre-COVID, because many services changed around the time of COVID. And in this review, we included all surgical referrals as well as endoscopy. Here, there were 167 consults for 120 patients over the 2-year period. The average age was 46, 47% were female, and similar comorbidities were most frequent in this population, as with the inpatient population. The most common referrals were for endoscopy, next OBGYN, next ortho and plastics and other specialties. 95% of referrals, and further divided these into system, provider, and patient level barriers. At a system perspective, there is a complex referral pathway, particularly for outpatient care, that required often multiple referrals from primary care to secure a correct appointment for the patient. There were rigid hospital protocols, both in the inpatient and the outpatient setting, that created barriers. For example, patients are required to have a ride home from endoscopy prior to getting their procedure. And in the inpatient setting, if patients leave and their bed is unoccupied for a certain number of hours, they are discharged from hospital. Further, again, the theme of kind of stigma, undertreatment of symptoms, and insufficient services and knowledge by providers around substance use. So, for example, patients who use opioids regularly and now need analgesia postoperatively, potentially being undertreated. And this barrier arose both at the system and the private provider level. Other provider level barriers included fees for missed appointments in an outpatient setting, or patients not being rebooked after missing one or multiple appointments. At the patient level, there are multiple barriers, including patients had trouble attending appointments or follow-up. Other literature has cited cost, time, knowledge around where to go and what to prepare for, anxiety around appointments. Many patients were hard to contact, including not having an address or a phone number, and sometimes needed to prioritize other needs, including shelter, safety, food, and sometimes substances. One of the interesting questions that arose from our scoping review was around the fact that we do know patients have higher burdens of care, trouble accessing care, but do unhoused patients have different surgical outcomes after receiving surgical care? And so we wanted to kind of explore this topic further. And specifically, some papers have talked about how they feel that homelessness is a contraindication, in this case, to joint replacement surgery, for example, or that there's an implicit high rate of readmission and mortality. And none of the papers actually were able to provide evidence to back up this perspective. So whether it's kind of surgical dogma or individual experience, we wanted to explore whether there's evidence to support this or not. And so recently I've been working on a mixed methods systematic review and meta-analysis to explore this question about postoperative outcomes. And so it has both a quantitative and a qualitative component. The quantitative component is looking to compare postoperative outcomes between housed and unhoused patients undergoing surgical procedures across outcomes including length of stay, complications, mortality, readmission, and reoperation. Looking at studies that use a direct comparison between unhoused and housed groups within a high-income setting. And then from a qualitative perspective, looking to explore perspective and experiences of both providers and patients throughout the surgical spectrum of care. Overall, there were 11 studies included, primarily retrospective studies, and primarily coming from the United States. These studies included some that were general, any surgical procedures included, whereas some were more specific, for example, ankle fixation, abortion, AAA repair. And we looked at 5 outcomes across these studies: length of stay, complications, mortality, readmission, and reoperation. And essentially, across all of these outcomes, there was no significant difference between unhoused and housed patients following surgical procedures. With readmission, there was a difference, with unhoused patients having higher readmission rates in the unadjusted analysis, but in the adjusted analysis, there was no difference. This is one example of a forest plot for one of the outcomes, unadjusted complications. And the effect size here is in log odds ratio, but the main point is to say that there was no significant difference between housed and unhoused populations across complications or any of the other outcomes examined. So again, no difference between housed and unhoused populations. There were a number of caveats with this study methodologically, and happy to discuss these more further. On the qualitative side, despite wide inclusion criteria, there were only 5 studies and were all very provider-centric. So there were actually no studies that interviewed patients experiencing homelessness about their experiences or perceptions around surgical care. Some of the themes that arose included a lack of services around kind of the perioperative care period, as well as appropriate disposition for discharge. The complexity and rigidity both of shelter and of healthcare systems that created barriers for these patients. Surgeons acted as gatekeepers of services, both with respect to admission and deciding when people would be admitted or how long they could stay in hospital, as well as around receiving or not receiving care. And then finally, surgeons did perceive homelessness to be a risk factor for injury, re-injury, non-compliance, higher risks of complication, and disability. Examining the qualitative and quantitative findings together led to some interesting insights. First was that in other populations, we use length of stay and readmission indicators as general indicators of successful postoperative recovery. But in this population, length of stay and readmission did not seem to be good indicators of recovery. Surgeons talked about, again, keeping patients in hospital longer because they didn't have an appropriate discharge disposition, or readmitting patients with a lower threshold because of their living situations. And so this wasn't necessarily reflective of recovery. Next, the perceptions of surgeons and other healthcare providers did not seem to align with the evidence, at least the evidence presented within this study, that unhoused patients were at higher risk of worse postoperative outcomes as compared to housed patients. Generally, there were greater barriers to care from an elective or outpatient side rather than inpatient side when care was emergent and usually streamlined. Finally, we were missing the patient perspective from both a quantitative side, for example, patient-centered outcomes like quality of life, as well as from the qualitative side where patients weren't included at all. And so we've talked about a lot of different things over the last 15 minutes, including broad evidence around surgical care and patterns of care for people experiencing homelessness. We've talked about the local experience in Hamilton of both inpatient and outpatient surgical care for unhoused folks, and then also a little bit about surgical outcomes compared to housed populations. So what are the take-home messages? Where do we go from here? I've tried to break it down by level. At the systems level, I do think it's worth noting that there is some success. Some patients are getting the surgical care they need. In one of the studies, outpatient procedures were happening 62% of the time for unhoused patients, at least in Hamilton. That said, the hoop that we make patients and their supports jump through to access this care are exceedingly high. Other areas of medicine, in particular infectious disease, psychiatry, primary care, have done a really good job at understanding and providing services to patients, including unhoused patients, but also other patients who have trouble accessing our rigid healthcare system the way it is. And I think surgery has a lot to learn from these other services. So this could include exploring alternative models, including wraparound care services where patients can see a number of different providers in one visit, so potentially including surgical providers in these kinds of outpatient settings. It could include more drop-in type outpatient clinics where patients aren't necessarily assigned a specific time, but can arrive when they can. This has been done with endoscopy procedures with some success. We need more safe dispositions for patients post-operatively. Some sites have tried respite care, which allows a patient to have a place to recover safely post-operatively. While there is a cost associated, it's cheaper than keeping patients admitted in hospital and allows patients to work with social work and other allied health to work towards a permanent placement. And then we talked about how metrics, including length of stay and readmission, are not necessarily accurate or helpful in this population, but could be replaced with more patient-centered metrics, including return to function, quality of life, and things like this. At an institutional level, some policies can be re-examined to ensure they're still protecting patients while not creating undue barriers. One example is that instead of requiring someone to drive you home following an endoscopic procedure, patients could be provided with a taxi chit or a bus slip. Given the high overlap between our unhoused population and folks who are using substances here in Hamilton, ensuring that sufficient substance use services are available to patients both in the inpatient and outpatient setting around the perioperative period is really important. Again, there are community agencies in Hamilton who are already working well with this population, including the Shelter Health Network and the Hamilton Social Medicine Response Team. And so we should be partnering with these agencies to ensure we're not reinventing the wheel, but are aligning with their practices. From a clinical perspective, there's room to rethink some of our perceptions and perhaps assumptions around people experiencing homelessness. Though the evidence shared today is low confidence, it shows that unhoused patients are not at a higher risk of poor postoperative outcomes, and so this should not be a barrier to urgent or elective surgical intervention. Using a harm reduction mindset might help us weigh the risks and benefits for each patient, and rather than waiting for housing before offering elective surgical management, recognizing that timely surgical management with appropriate supports can improve quality of life and reduce disease burden. And then using a trauma-informed approach with every patient is important to meet them where they're at, and recognizing that they may require a little bit more time and a little bit more care given a history of negative experiences that many patients have with the healthcare system. For future research, it's so important to include patient perspectives through the entire research process. So from deciding which outcomes to investigate, including patient perspectives in quantitative, qualitative, or mixed methods data, and then working with patient representatives in the interpretation and knowledge translation aspects of research. We need to develop specific interventions to reduce barriers and increase access, again with patient input, so that we're not relying on provider instinct of what might work. And then we need to rigorously test these interventions. This is a growing body of research, and so future studies can confirm or refute the findings presented here. And then eventually, hopefully, once we've amassed a significant body of evidence, we can create specific surgical care guidelines for patients experiencing homelessness. Thank you for lending me your ear, and happy to take any questions.
Their questions. I want to thank both speakers. The presentations were excellent, very thought-provoking, both of them, and I thank both of you for taking the time to prepare this and be available to us while you're working and while you're, on another continent. So thank you both. If this has been recorded, so if people have an interest, it'll be David, you'll have it posted through MacGlObAS, I assume. And if people have any suggestions for future seminars, any topics, any presenters, please contact us.